lecture I will be talking about adrenocortical insufficiency, the two types, that is primary and secondary adrenocortical insufficiency, the causes, signs and symptoms, and how to diagnose and differentiate primary adrenocortical insufficiency from secondary adrenocortical insufficiency. So corticosteroids are grouped into glucocorticoids and mineralocorticoids. Glucocorticoids include hydrocortisone or cortisol, prednisolone, dexamethasone, betamethasone, and paramethasone. In the mineralocorticoid category, we have aldosterone and fludrocortisone. So before discussing primary and secondary adrenocortical insufficiency, it is important to understand the regulation of glucocorticoid secretion. The regulation of glucocorticoid secretion is a process that involves the hypothalamic pituitary adrenal axis. So the hypothalamus is the starting point and it releases CRH, that is corticotropin releasing hormone. So the factors that influence the release of CRH are stress, both physical and emotional stress, circadian rhythm, where the cortisol levels peak in the morning time and it is lowest in the night time. Thirdly, feedback from blood levels of cortisol also influence CRH secretion. So if the blood levels of cortisol increases, the CRH secretion from the hypothalamus decreases. So these are some of the factors that influence the release of corticotropin releasing hormone from the hypothalamus. So CRH is released from the hypothalamus, which in turn stimulates the pituitary to release ACTH. ACTH in turn stimulates the adrenal cortex to release and secrete cortisol into the blood circulation. So cortisol secretion is dependent on ACTH. It is to be noted that the adrenal cortex, besides producing cortisol, also synthesizes and produces aldosterone. But the regulation of aldosterone secretion is under the control of renin-angiotensin-aldosterone system. So cortisol secretion is regulated by ACTH, but aldosterone secretion is under the regulation of renin-angiotensin-aldosterone system. So the next question is cortisol important and how is it important for our body? So this I have discussed in detail in my previous lecture, where I have explained that cortisol is very important for metabolism, for immune response, to manage stress and many other vital functions of our body. So the cortisol levels are maintained at an optimal range through a tightly regulated feedback mechanism. So what is this feedback mechanism? As we can see here, when the blood levels of cortisol rises, there is a negative feedback inhibition to the hypothalamus, decreasing the release of CRH, and also the feedback reaches the pituitary to decrease the release of ACTH. So decreased release of CRH, decreased release of ACTH decreases the cortisol production. And if the blood levels of cortisol decreases, the CRH and ACTH secretion increases to stimulate the adrenal cortex and to maintain the cortisol levels in the blood. So this is how the cortisol levels are maintained at an optimal range, and this is important for performing all the vital functions of our body. So let's now discuss adrenocortical insufficiency, which is characterized by insufficient production of adrenal hormones. So it is of two types, primary and secondary adrenocortical insufficiency. In primary adrenocortical insufficiency, there is a defect or disorder in the adrenal glands in the adrenal cortex, which results in decreased production of cortisol and aldosterone into the circulation. So there is a defect or damage to the adrenal cortex resulting in decreased adrenal hormones. So what are the causes? In developed countries, autoimmune destruction of the adrenal glands is common, and in developing countries, tuberculosis of adrenal glands is a common cause. Also, adrenal hemorrhage and infarction can destroy or damage the adrenal glands, and this results in decreased cortisol levels. There are certain genetic disorders such as congenital adrenal hyperplasia, where there is a defect in enzymes that are responsible for the synthesis of steroid hormones, and this results in decreased cortisol levels. Also, certain medications such as ketoconazole, etomidate inhibit steroid hormone synthesis, and this decreases the cortisol production. So these are some of the factors that affect the adrenal glands resulting in decreased cortisol levels, decreased aldosterone levels, and the defect is in the adrenal gland. So in primary insufficiency, the issue is in the adrenal glands. In secondary adrenocortical insufficiency, the defect or the disorder lies in the pituitary. So certain pituitary tumors such as the benign or malignant tumors that can compress or damage the cells of the pituitary, decreasing the release of ACTH. Also, surgical removal of the tumor or radiotherapy for tumors can cause damage to the pituitary gland, and this can reduce the cortisol levels. Pituitary infarction, a condition known as Sheehan syndrome, where there is postpartum pituitary necrosis. So there is necrosis of the pituitary gland postpartum, and this condition is known as Sheehan syndrome, and this decreases the cortisol production. Also, hypothalamic disorders, for example, tumors in the hypothalamus or surgical removal of the tumors, radiotherapy for tumors can damage the hypothalamus, decreasing the release of CRH, which in turn decreases the ACTH release and the cortisol production. Thirdly, chronic glucocorticoid therapy, for example, prolonged use of glucocorticoids for certain disease conditions such as rheumatoid arthritis, autoimmune disease, asthma, can cause suppression of this hypothalamic pituitary axis. So because the hypothalamic pituitary axis is suppressed, so abruptly stopping the glucocorticoids, the suppressed hypothalamic pituitary axis may not resume the normal ACTH production. So ACTH production is decreased, it is suppressed, and this in turn reduces the cortisol levels in the blood. Thus, primary adrenal insufficiency is due to a defect in the adrenal gland, and secondary adrenocortical insufficiency is due to defect in the pituitary and the hypothalamus. Now coming to the signs and symptoms of primary and secondary adrenocortical insufficiency. So as we have discussed that in primary adrenocortical insufficiency, the adrenal cortex is involved. So because the adrenal cortex is involved, there is decreased production of cortisol and aldosterone. So because of aldosterone deficiency, there is loss of fluid from the body, and this can cause hypotension. Also because of aldosterone deficiency, there is loss of sodium from the body, and this can cause hyponatremia and retention of potassium, that is hyperkalemia. So electrolyte imbalances are common because of aldosterone deficiency, and the common electrolyte disturbances are hyponatremia and hyperkalemia. Also, there can be salt craving because of sodium loss from the body, hyponatremia, and also the body's attempt to maintain normal sodium levels in the body. So there can be salt craving, and this is because of aldosterone deficiency. So aldosterone deficiency causes hypotension, electrolyte imbalances, and salt craving. So now let's see what are the signs and symptoms due to cortisol deficiency. First, weakness and persistent fatigue can occur because cortisol plays a crucial role in energy metabolism. So fatigue and weakness are common symptoms. Secondly, weight loss and decreased appetite can occur because cortisol plays an important role in regulation of appetite. Thirdly, GI symptoms such as nausea, vomiting, diarrhea, abdominal cramps is common because cortisol is important for maintaining normal GI motility. So deficiency of cortisol leads to increased GI motility, causing abdominal cramps and abdominal pain and diarrhea. Fourth, hypoglycemia or frequent episodes of low blood sugar can occur. This is because of deficiency of cortisol, which plays an important role in gluconeogenesis and nutrient metabolism. So because of decreased gluconeogenesis, the blood glucose level in the circulation decreases, and this can cause hypoglycemia. Also, deficiency of cortisol can cause mental health issues such as irritability, insomnia, mood dysregulation, or depression. And this is because cortisol plays an important role in brain function and mood regulation. Lastly, hyperpigmentation, particularly in areas exposed to friction, pressure, or sunlight, and this is because of increased secretion of ACTH in primary adrenocortical insufficiency, and increased ACTH stimulates the secretion of melanocyte stimulating hormone, which increases the production of melanin in the skin, and this causes hyperpigmentation. So cortisol deficiency can lead to weakness, fatigue, weight loss, anorexia, nausea, vomiting, hypoglycemia, mental health issues, and hyperpigmentation in exposed areas of the skin. So now that we have discussed about the signs and symptoms causes of primary and secondary adrenocortical insufficiency, let's now differentiate primary adrenocortical insufficiency from secondary adrenocortical insufficiency in terms of clinical evaluation, laboratory tests, imaging studies, and treatment. So in terms of clinical presentation, in primary adrenocortical insufficiency, there is severe electrolyte imbalance, and this is due to aldosterone deficiency because of damage to the adrenal glands. So aldosterone deficiency can lead to severe electrolyte imbalance causing hyponatremia, hyperkalemia, and also hypotension is significant. Whereas in secondary adrenocortical insufficiency, there is disorder of the pituitary gland, therefore aldosterone secretion is less affected, so there is less severe electrolyte imbalance, there is no significant hyponatremia or hyperkalemia. So electrolyte imbalance is less common in secondary adrenocortical insufficiency. Secondly, hyperpigmentation typically occurs in primary adrenocortical insufficiency, and this is due to increased secretion of ACTH. Whereas in secondary insufficiency, there is a disorder in the pituitary gland, decreasing the ACTH production, and because there is decreased ACTH production, decreased melanocyte stimulating hormone, and therefore there is no evidence of hyperpigmentation in secondary adrenocortical insufficiency. So this is with respect to the clinical presentation of primary and secondary adrenocortical insufficiency. Next is, how do we differentiate primary and secondary adrenocortical insufficiency in terms of laboratory tests? So the first laboratory test is morning serum cortisol and ACTH secretion. So if the cortisol secretion is low and ACTH secretion is also reduced, it is a case of secondary insufficiency because the disorder is in the pituitary gland, decreasing the ACTH and decreasing the cortisol levels. But if the cortisol levels are low but the ACTH secretion is high, it is a case of primary adrenocortical insufficiency. So the defect is in the adrenal gland, whereas the pituitary gland is normal, leading to normal ACTH secretion. So if both ACTH and cortisol secretion is reduced, it is a case of secondary insufficiency. And if the ACTH secretion is normal and cortisol production is reduced, then it is a case of primary adrenocortical insufficiency. The second laboratory test is ACTH stimulation test, where we measure the baseline corticosteroid levels. We administer a synthetic ACTH and we measure the steroid levels after 30 to 60 minutes. So if after administering synthetic ACTH the cortisol levels are increased, it indicates that the adrenal gland is normal and it is a case of secondary insufficiency. But if there is blunted or decreased cortisol levels in the circulation, it indicates that there is a disease in the adrenal gland and it is a case of primary adrenocortical insufficiency. So if after administering synthetic ACTH cortisol levels are reduced, it indicates primary adrenal insufficiency. The defect is in the adrenal gland. But if the cortisol secretion is increased, it is normal. It indicates that the adrenal gland is normal and the defect is in the pituitary. The third laboratory test is plasma renin activity, and we have learned that aldosterone is under the control of renin-angiotensin-aldosterone system. So deficiency of aldosterone leads to compensatory response, increasing the plasma renin activity. So the plasma renin activity is high in aldosterone deficiency, which occurs in primary adrenal insufficiency where there is a disorder of the adrenal glands. Whereas in secondary adrenocortical insufficiency where there is a problem or issue in the pituitary gland, the plasma renin activity is normal. Now, with respect to imaging studies, if the adrenal glands are affected in primary adrenocortical insufficiency, the adrenal glands will appear atrophied or calcified because of tuberculosis, or it will be enlarged. So, there is a defect in the adrenal gland, and this indicates primary adrenocortical insufficiency. Whereas if the MRI shows structural abnormalities in the pituitary gland or tumors in the pituitary gland, then it is a case of secondary adrenocortical insufficiency. So in terms of treatment, if it is a case of primary adrenocortical insufficiency where there is a disorder of the adrenal glands, there is deficiency of aldosterone in addition to deficiency of cortisol. So replacement therapy with fludrocortisone is required in addition to hydrocortisone therapy. Whereas in secondary adrenocortical insufficiency where there is a problem in the pituitary gland, the cortisol is deficient but the aldosterone production is normal. So replacement therapy with fludrocortisone, which is an aldosterone, is not necessary. Therapy with hydrocortisone is adequate if it is a case of secondary adrenocortical insufficiency. So if you find this video useful, please like and subscribe to this channel. Thank you for watching.